directly at the camera because I'm just basically looking at my notes to keep me moving along smoothly. It's hard when you do virtual stuff.
Hi, and good morning. And we're so happy that you have joined us this morning. You are looking at the live stream of the People's Church of the Harvest, Church of God in Christ, where we are located at 3570 West Fifth Avenue in Chicago on the west side, the best side. And we're coming today. Of course, you know our pastor's name is Pastor Michael Eady, the greatest pastor in the whole wide world. And we are coming today and we're talking about a topic that I think is very important. And people don't talk about it until it's getting ready to happen. And it's talking about being afraid of anesthesia. And I'm coming on behalf of our women's department today. Our president is our beautiful flower, the fragrance of the house, Lady Christine Rose Eady. I am missionary Sharon McDavid, and we're going to be talking to a wonderful, wonderful person on today. Her name is Dr. Nakia Hunter. And it's going to tell you a little bit about her, and then I'm going to get out of the way so she can do her thing. But Dr. Nakia Hunter is a board certified anesthesiologist, which means she is the real deal. Amen. Amen. She has a subspecialty training in obstetric anesthesiology. Dr. Hunter is a native of Southfield, Michigan, a neighboring suburb of Detroit, Michigan, where most of her family resides. She received her undergraduate degree from the University of Michigan, Ann Arbor, where she became a member of Alpha Kappa Alpha Sorority, Inc. Dr. Hunter received her medical degree from Michigan State University College of Human Medicine. She completed her residency training in anesthesiology at The Ohio State University and her fellowship training at Prentice Women's Hospital at McGaw Medical Center of Northwestern University. Dr. Hunter currently works as a general anesthesiologist at Loyola University of Chicago Hospital, where she serves as the co-director of obstetric anesthesiology. She enjoys traveling and trying new restaurants. The title for what she's going to be talking about today is Afraid of Anesthesia? Let me calm your fears. There are so many people that are afraid of anesthesia, which means being put to sleep. And she's going to talk about that today, that she's going to calm your fears about anesthesiology. Can you please send up some love, some hearts for Dr. Nakia Hunter, MD?
Thank you so much, Sister Sharon McDavid, for that wonderful introduction. And I just wanted to start by thanking Pastor and First Lady Edie for the opportunity to speak with you today. So I'm just honored to be able to speak to you about something that I love and have pretty much dedicated my life work to, and that's anesthesia. So as Sister McDavid said, that I am a board certified anesthesiologist, and most of my practice is doing general anesthesia. So that's basically doing anesthesia for common procedures like joint replacements, colonoscopies, brain surgery. And then, as she mentioned, I do have specialty training in obstetric anesthesia, where I specialize in doing anesthesia for women during their pregnancy. So, giving anesthesia to patients is something that I do every day, and it comes very easy to me. But I know that it can be scary if you are on the receiving end. So, I
Yeah.
just wanted to provide some insight on the practice of anesthesia and really how to prepare for your upcoming surgery. And hopefully, this will ease some of your fears about receiving it. Okay. So many people, as I mentioned, are afraid of anesthesia. And just to let you know that you are not alone. Some common things that I hear are, I'm afraid of not waking up, or I'm afraid that I may wake up during the surgery and not be able to move. Or some people are afraid of getting a needle being placed in their back with the fear of being paralyzed. Or they may worry about simply just being in too much pain after their surgery. And I know
Yeah.
many of you have asked yourself these same questions. And most people fear anesthesia because they don't know much about it. And if there's a lot of unknowns about something, it's very hard, I know, to put someone else in control of your life. And this is a natural feeling, but just know that it is exceedingly rare to have any serious or any fatal complications due to anesthesia, especially being paralyzed. And usually, if anyone does remember any portions of the procedure, most of the time this is done intentionally just so the anesthesia can be safe for you. Or sometimes it might be the case in an emergency situation. But all routine surgeries that are scheduled, it is highly unlikely for any of these complications to occur. So anesthesia is safe, as I mentioned. In fact, it is actually more likely for you to get struck by lightning or even get into a motor vehicle accident in your lifetime than from you having a serious complication from anesthesia. So we have made some huge advancements in our monitoring and equipment since the 1970s. So having any of these complications have the rates have drastically been reduced. So I want to start by talking about who actually gives you anesthesia. Who are these people that you meet in the morning, first thing in the morning for your surgery, and a few minutes later they put you to sleep? So just to familiarize you all with who's taking care of you. In most hospitals, you will have a physician anesthesiologist that's involved in your care, and he or she is a highly skilled medical expert in anesthesia care, pain management, critical care medicine, and we have the education and the training that means the difference between life and death. So, in other words, we will work really hard to keep you alive during surgery. So, working
Dr.
under our,
I'm
yes,
sorry, I just want to interject in right in here. Can you explain the difference between or the who's who with the anesthesiologist, the certified nurse anesthetist, and the resident? Can you explain those different positions?
yes, I sure can. Both a certified nurse anesthetist and an anesthesia resident, and also an anesthesia assistant, which is in maybe 4 or 5 states in the US, they work under the supervision of a physician anesthesiologist, and I'll go through the training that's required for each one. Um, but just know that this is like the structure. So I'll go through the different breakdown on the next slide.
Okay.
So and physician anesthesiologist is able to supervise multiple surgeries at the same time, and they have certified or qualified personnel in each room that they're supervising that can deliver anesthesia care. And an anesthesiologist is always available to intervene and to quickly respond to any emergencies that may or complications that may arise during the surgery. And then also included in the team are trainees. So we have training nurses for nurse anesthesia, medical students, and then we might even have some circulating surgery residents or trainees as well. So, just to break down what type of education is required for each of the specialties. So, to become an anesthesiologist, you must complete 4 years of a undergraduate education or degree, and then you apply for medical school, which is very competitive. And then you complete 4 years of medical training in order to get your doctor of medicine. And then you go on to complete 1 year of internship in the hospital where you rotate through several surgery specialties, the ICU, internal medicine, and even the emergency department. And then you go on to do 3 years of anesthesia specific training where you learn how to do anesthesia for all different types of surgeries and anesthesia for anyone with any different type of medical conditions. So then we have the nurse anesthetist, or also called the CRNA. So they have specialty training in anesthesia as well, but they are the nurses to the anesthesiologist. So they receive a bachelor's degree, which is a 4 year degree, usually in nursing. And then they go on to work in the ICU for a minimum of 2 years. So they have critical care training and know how to manage patients with critical illnesses. And then they get their anesthesia specific training, which is a 2 year program that is very vigorous. And then they also go on to actually get board certified in order to deliver anesthesia care. And it's typically under the supervision of a physician anesthesiologist. And then we also have in some states within the US a anesthesiology assistant. So that's when someone gets a 4 year bachelor's degree and then have 2 years of anesthesia training. And they always have to be under the supervision of an anesthesiologist, and they typically do more routine, scheduled, like outpatient surgery type of procedures. Does that clear up the difference between
Yes,
the
because
two?
I just want people to know, there are different levels of people that are involved in your anesthesia when you are getting ready to be put under. And I just want them to know the different levels of who are you, and who are you, and what do you do, because when it's just a scary thing,
Yeah.
about being put to sleep. And so I tell people all the time, ask all the questions that you want to ask. And there's no stupid question. There's no silly question. This is about what's getting ready to happen to you. And you should have a clear understanding, especially with the people that are getting ready to put you to sleep.
Right. So again, these are the key players. We all work together as one cohesive team to take care of you. So one surgery, you may have a certified nurse anesthetist that's in the room with you at all times. You might even have the anesthesiologist, him or herself, that's taking care of you throughout the procedure, or you have an anesthesiology resident, so basically training to be an anesthesiologist. But
Mhm.
all of them have the qualifications to monitor you during your surgery. Okay, so now that brings us to the question of what is anesthesia? And most people don't really understand what it is. And by definition, it is the state of having a controlled temporary loss of sensation or awareness. And this is for medical purposes. So, in other words, we give you medications that will alter your level of consciousness in order to keep you comfortable and pain free during surgery. So, there are four different types of anesthesia. General anesthesia is what we probably do most commonly, and that's when you have a loss of consciousness and you are in a very deep sleep. And loss of consciousness means it's a deeper state than a regular sleep because you're so deep in a sleep that you will not respond to the stimulation of the surgery itself. And then we have IV sedation, or also called monitored anesthesia care, where we give you IV medications to help you relax, or you may even be like in a normal night's sleep. And then we also have local anesthesia. So local is like what you would receive at a dermatologist's office, such as
Mhm.
getting a mole removed where they just numb up a very small area of your skin, or even like going to the dentist when you get any dental work done, they numb up an area of your tooth or your gums in order for you to be comfortable during the procedure. And then we have regional anesthesia, and this includes epidurals, spinals, and we also do targeted nerve blocks. So basically, it's injecting medications in an area near a nerve to numb up that so you can be comfortable during your surgery. And then now I'm going to briefly explain each type.
Okay.
So, general anesthesia. So, as I mentioned, medicine is given through an IV or in a mask to keep you unconscious. And this is administered by a physician anesthesiologist. So we calculate your exact dose of medication based on your age, your weight, and then we also alter our anesthetic and mainly the technique and the dosing based on any condition, medical condition that you do have. So, for example, if someone with heart disease or even someone with dementia is getting surgery, we actually do tailor our medications and combinations of such, or even tailor our technique to minimize any harm to you. So, general anesthesia is needed for major operations such as spine or heart surgery, or even any surgery that you may need to work on the colon or your stomach. So, during the surgery, the physician anesthesiologist is going to support your breathing. And to support your breathing, this requires us to temporarily place a breathing tube in the throat. But this allows us to really help you breathe because you want to be in such a deep state of sleep to where you won't be stimulated at all by surgery. So that do require us to give you oxygen and also to support the breathing a little bit more. And we monitor your vital signs throughout the surgery. So we monitor your heart rate, your blood pressure, oxygen levels, and even your temperature continuously. So know that there's always someone that's watching you, making sure that there are no abnormal findings during surgery. And if there is anything that occurs during the surgery, we can promptly respond to it. So just
So,
know that there's always a qualified provider in the room.
so Dr. Hunter, there's a question that I see on our Facebook Live, and
Okay.
Latricia Estes is asking, what happens when it's hard to wake up from anesthesia? She said one time it was hard for her to be awakened coming out of anesthesia. So can you explain what happens there when that happens? It looks like Dr. Hunter has frozen a little bit, so um, we're going to make sure that this is corrected. But again, we're talking about today in our PEME session, and we are coming on behalf of our women's department, which is headed by our wonderful First Lady, uh, Sister Christine Rose Edie, the fragrance of the house of the People's Church of the Harvest, Church of God in Christ. She is the leader of our women's department. And every fourth Sunday, we will be coming forward to you with different topics that are relevant to us, not only just as women, but to everybody, that someone can benefit from what topics that we are bringing forward to you. And just so if you don't know, I do work in the Department of Anesthesiology at Loyola. So I'm very familiar with a lot of things that Dr. Hunter is talking about, and people being fearful of anesthesia. And one of them is a fear of not being able to wake up. What do you do when it's a person that is there that is hard to wake up from anesthesia? And it looks like our Dr. Hunter is back with us.
Yeah,
Yes.
sorry about that. I think my internet cut out for a moment. So I had to log back on. Sorry about that. So, yes, you wanted to know what we do if it's hard to wake someone up. So, there are several reasons why it may be challenging or slow for someone to wake up. Typically, it's due to just we have to wait for the medications that we give to actually be metabolized. So, typically, what we do to wake someone up is we reverse medications that we give, and usually people regain consciousness within a few minutes. But sometimes just giving people's different medical conditions, like having heart disease or having kidney disease or even any lung diseases, it may take a little longer for someone to recover from anesthesia. And it often just requires us to give medications to further reverse the effects of the anesthesia, or we might just need to give it time. Some people, we will just wait for a while until you wake up completely. But we honestly don't get many situations where we cannot wake patients up because we will tailor our anesthetic to avoid any medications or anything that may be more harmful to you. So a lot of times people will say, oh, it took me a while to wake up, when in fact it really did not take that long. It just felt like it was a long time for you. But from an anesthesia standpoint, from the physician side, if you are responding to us, if you're breathing on your own, if your vital signs are stable, then you are awake from our standpoint, but you may not feel completely awake from your side. So you might still feel like you have a lot of sedation on board or very drowsy. But as long as you are still awake and able to talk, you might just feel like you are taking a while to recover when you are indeed awake. Does that answer your question?
Yeah, I think that answers her
Okay.
question. Thank you.
Can you still see my screen?
I can.
Okay. So then I also, as I was mentioning, we will give you medications throughout the surgery to keep you comfortable. So typically when we put the breathing device in, we will have you breathing a gas throughout the entire procedure. Then we also give you pain medicine throughout the procedure, or even any other medications through the IV to make sure you're nice and comfortable.
Mhm.
And once we turn off the gas, once we stop the IV medications and we reverse all of the stuff we gave to help your muscles relax, you usually wake up within about 10 minutes or so. And most people actually wake up in the operating room. We take the breathing device out and we take you to recovery, but most don't remember being in the operating room, but you are awake. And everything we give causes amnesia, so you don't remember that little part in between until the anesthesia has completely worn off.
You are correct because I
Yes.
remember having surgery and going in and they says, "Okay, Sharon, count back from 100," and I go 99, and I don't remember anything else.
Yep.
And then I'm in recovery and it says, "You're doing like this. Wake up, wake up, wake up." And I was like, "When are we gonna do the surgery?" And he's like, "What? We're done." I was like, "Okay."
Yes, you lose a lot of time with anesthesia, but you get a good nap.
Yeah, definitely.
Um, so, as I was saying earlier, major complications are exceedingly rare. And most common side effects that people experience are nausea, maybe some mild discomfort, and like I was saying earlier, feeling a little drowsy or sleepy until the medicine has completely worn off. And you typically spend on average about 2 hours in the recovery room before you're able to be discharged home or transferred to your inpatient room. And some other complications are allergies as well. Um, but we often don't really see true allergies to anesthesia. And we, of course, avoid any medications that you have listed as an allergy.
So, Dr. Hunter, if someone is deem themselves to be hard to wake up because Trish was saying that she could hear them say, "Why isn't she waking up?" You know,
Hmm.
but it was kind of hard for her to come out of the anesthesia. So, what is does that mean?
So that means, as I was saying earlier, it may just be that you are metabolizing the medications that we give a little slower than the average person. And all that means is we have different studies and tests that we can do very quickly to let us know what the cause is for you not waking up. I would
And this
assume
can
that
happen.
you
I'm sorry, but this can happen to a healthy person, correct?
It can. It can happen to a healthy person because we don't know how quickly your liver or your kidneys are going to metabolize it. And some people do have different medical conditions or genetic conditions that might slow down their metabolism, or any medications that may interact with the anesthesia, which is why we say, don't take any multivitamins or anything that's not actually prescribed by a doctor because it could interfere with the anesthesia. However, even if that is the case, we have all of the tools, the medications to reverse anything that we have given.
Okay.
All right. In terms of the next type of anesthesia, so this is monitored anesthesia or IV sedation. And this is when we give IV medications to help you relax. And sometimes you do fall asleep. This is often called conscious sedation or even twilight anesthesia. But just know that you will not be unconscious. And you
Mm.
most likely won't remember the procedure just because everything we give does cause amnesia. And a lot of people will remember little bits and pieces of the procedure, but not the actual act.
Mm.
So there are varying levels of sedation based on the procedure that you are receiving. You could be fully awake, but feeling like, oh, the edge is taken off and not really anxious. And this is called minimal sedation. And we often do this for cataract surgery because your eye is numb. It's really just to make you comfortable while you're sitting there for a few minutes in order to tolerate being still on the bed. You can also be a little drowsy or even fall asleep, and you will still remember bits of the procedure. And this is called moderate sedation. And then we
Mm-hmm.
have deep sedation, where you are really asleep, and it's almost like a normal night's rest, but you're not unconscious. So you're still breathing on your own, but you will have little to no memory of the procedure itself. And this is often the type of anesthesia that we administer for colonoscopies. So some
Mhm.
people will say, like, oh, I remember being back there. I remember seeing some stuff on the screen. That's all normal. So our goal is just to keep you comfortable so you don't have any pain or discomfort. But it's not to put you completely unconscious because we still want you to breathe on your own, and we
Okay.
just want to, be there just to support you.
Yeah.
But like I said, despite the level of sedation, you will still be breathing on your own. We will give you some oxygen, but we will not be breathing for you.
Hmm.
Okay. So just like general anesthesia, there's always a qualified anesthesia provider that's going to be there with you the entire time, monitoring all of your vital signs, the heart rate, the blood pressure, and your oxygen levels as well. And as soon as we stop giving you that medication during the procedure, you do wake up within a few minutes within receiving the medications, and then you'll go to recovery. And typically, the recovery from the sedation cases are much quicker and typically are an hour or less. And there are overall fewer side effects compared to general anesthesia. You could be a little sleepy or drowsy, maybe a headache, and also some nausea. But typically, we give medications to treat the nausea or prevent you from having a headache when you wake up. And then we can give you more if you do experience those side effects once the surgery is over. Any questions about the IV sedation?
No, but I just want to let you know that Alice Cannon made a comment. She says, "Thank you, Sharon, for having Dr. Hunter on this morning. Valuable information." She says she loves it. And I'm telling you, with the
Oh, awesome.
anesthesia, I'm telling you, people need to know about it because there is definitely a fear of being put to sleep and not waking up.
Right,
So
right.
thank you, Dr. Hunter.
No problem. Happy to be here. So, the last form of anesthesia that I'm going to describe is called regional anesthesia. So, this is our best form of pain management for any surgery or procedure that's going to numb up an area of the body so the surgeon can work. So, there are three different types of regional anesthesia: spinal, epidural, and a peripheral nerve block. And this picture to the left actually depicts what we do for regional anesthesia very well. It shows a cool way of how the body is wired. And the body is split up into these different sections called dermatomes. And each dermatome is a strip or an area of your skin that is the sensation and the movement is controlled by one nerve. So we can literally numb up an area of your back that will correspond with numbing up an area of your body or your skin. So we target those specific nerves in order for you to get surgery in that area.
Mhm.
Does that make sense?
Yeah, so this is the one when you talked about the epidural
Yeah.
that people are really fearful as well because
Mhm.
it's in the back and
Right.
the fear of being, as you said earlier, paralyzed. So I had a lot of people, I don't want nothing in my back,
Yeah.
like that. But with your anesthesiologist, they are trained to know that
Yeah.
particular spot where they need to place that anesthesia. But I want to ask you too, because I know
Mhm.
you have a lot to do with obstetrics. And
Mhm.
what determines whether a pregnant woman has an epidural versus being under general anesthesia?
So there are a few reasons that will disqualify you from being a candidate for either a spinal or an epidural. And the first reason is patient refusal. So if you don't want it, of course, we'll never force you to do that. If you have an infection that's near the area that we're going to inject the medicine, we won't do it. And
Okay.
if you have any type of mass in the spine or mass in the brain or tumor or any signs that you have an increased pressure in your brain, we won't do it either. And then we
Mm.
also look at whether you're on any blood thinners or have any inherited bleeding disorders. And depending on what your labs look like your platelet counts and what medications you have to be off of blood thinners for a certain amount of time, before doing it, but we always screen people very well and thoroughly before doing any type of procedure like this.
Mhm.
So we look at your laboratory values, we ask you specific questions about bleeding, we look to make sure that you don't have any type of infections that we don't know about. We
Mhm.
also look at your heart and see if you have any issues with shortness of breath or chest pain. If there's any signs that you have any significant heart disease, or I should say severe heart disease, then we also won't do it in that case either. But it's on a case by case basis, and we do a very thorough risk assessment before determining who can get it. So anyone that has an increased risk of any complications from placement of the spinal or epidural, we just won't do it. And it's actually pretty rare for you to have an absolute contraindication that says like, oh, this person absolutely cannot get an epidural or get a spinal. Now, just to give you a little bit of information about what the spinal and epidural is. So you have your spinal cord and it's protected by bone. And then deep to that, or right outside of the spinal cord, you have several layers of dense tissue that's protecting it. So we actually place an epidural outside of those protective layers. So we really don't come very close to the spinal cord itself. And with the spinal specifically, it's a single shot or injection in the back. It's very low in the back, and it's actually below the level of your spinal cord. So your chances of having direct trauma by a needle is very low because there are no nerves right there. It's just putting it into a space that's going to basically travel or migrate and bathe those nerves that supply sensation to that area. But the needle itself does not come close to a nerve.
Yeah, so
And
I'm glad you said that because I'm
yes,
telling you, I've heard them. I don't want to be paralyzed, but you're saying that it's below that. Where
yes, it's below the actual spinal cord.
see,
The
that's good
cord
to
is
know.
spinal for sure. When you do an epidural, we can do epidurals at different levels of your spine from the neck all the way down to the lower back. But we are very trained, we know anatomy very well. And what we do is we know exactly how deep we are based on how your anatomy feels. So
Hmm.
again, we place the epidural or we access the epidural space, which is outside of the spinal cord, outside of those protective layers. And then we just put a catheter, which is a little tiny tube in that area. No
Okay.
needles are left. You will get medicine every hour. And once we turn that medicine off, then you will regain sensation in that area that it's blocking.
Okay. Okay.
Um,
Dr. Hunter, does weight play a part in whether or not a person will have a spinal or an epidural?
no, you can do any of these techniques on someone who's very small. We even do these techniques on babies, and
Mm.
all the way up to older patients. Doesn't matter the age, it doesn't matter the weight. We will still try to do what's called the regional anesthesia because it's actually safer in cases of a C-section to get a spinal or get an epidural during the case, so you can stay awake. We don't have to put a breathing device in. Regional anesthesia is always going to be viewed as relatively safer than general anesthesia, but depending on the type of surgery you get, we may not be able to numb you up in that area safely or adequately in order for you to be pain free. So, like for example, if you're getting a knee replacement, it is going to be safer for you to get a spinal as long as you don't have any other contraindications or anything that doesn't make you a candidate for a spinal. Because we can still give you sedation to where you're breathing on your own, you're basically just sleeping, but you will have better pain control, you won't feel the surgery, and overall, your need for any narcotics after surgery is significantly reduced because regional anesthesia is our best form of pain control.
So, have you ever had the instance where you started off with a spinal or epidural and had to graduate to a general anesthesia?
There are sometimes we have to do that, but that is also rare. So if we, let's just say we're doing a hip replacement with the spinal and we just do that one shot, if the surgery is taking longer, we may have to convert to general anesthesia just because the medicine only lasts for about 2.5 to 3 hours. So if for any reason the surgery takes longer, we may have to convert to general anesthesia. or if we get into a situation where there is a complication on the surgery side, then we may have to go ahead and stabilize you even further by putting you under general anesthesia. But this does not happen often.
Okay.
And in terms of the length of the procedure, some C-sections we place epidurals, and that way we can dose the epidural once the spinal medications wear off. So we can still keep you nice and numb and comfortable for your delivery or any other surgery. So it really just depends on the situation, but there are ways that we can try to avoid putting you completely asleep under general, or we may feel that it is safest for you to get general anesthesia in that case. All right. So in terms of complications for these procedures, they're exceedingly rare, like a 1 in several 100,000 chance for you to get an infection back there caused by us. We used all sterile equipment, and we clean up your back very well with special soap and make sure that dry before we do the procedure. Um, Bleeding is also very rare. As I said, we do screen people. Anyone who has an increased bleeding risk, we just won't do it. And
Mm-hmm.
also paralysis, that is very rare. We have not seen any cases like that in I would say a few decades,
Oh,
because,
that's
like I
good.
said, we screen people so well. And if you have any increased risk of that, we don't do it. And the needles are actually pretty small. They're tiny needles, so they don't cause much trauma or damage to the nerve if it even did come close to one. It just would not do that.
Mm-hmm.
You would have to be extremely negligent um, for you to have a complication like that. And as I mentioned before, anesthesiologists and even nurse anesthetists are very well qualified and trained to do these procedures. And myself, I mean, I've done over 1,000 of these procedures, even with it being very early in my career.
Mm-hmm. Okay.
So another thing I wanted to mention is that the procedure does not hurt. Well, it should not hurt. So we do numb up an area of your skin, but there aren't any nerve endings that's deep to the fat layer of your back. So once you're a little deeper to that and close to the epidural space, it's just going to feel like pressure. And that can be uncomfortable, but you really should not feel any sharp shooting or stabbing pains during the procedure.
I can deal with the pressure, but no pain.
Yeah, but it's typically well tolerated by most people.
That's good.
Okay, and then since we're running close to time, my last slide is just basically how do you prepare for surgery? What are some things that you can do to minimize your risk? For one, I just want to say do not put off having any procedure or surgery. Waiting to get a surgery can be detrimental to your life because
Right.
you might be putting off a diagnosis that may give you um, more time to treat whatever condition that you may have. Um, for example, we know that we have to get colonoscopies at the age of 50 or maybe even earlier for some that have a family history of colon
Yeah.
cancer. Don't put that off. Remember, our community have higher rates of heart disease, cancer, and a lot of medical conditions. So it's better if you find out about these things sooner, and you just want to make sure that you take care of yourself first and foremost. And when you have a surgery that's coming up, just focus on the things that you can control. Yes, you may not know what's going on when you're asleep, but you just have to trust that your anesthesia team is going to take great care of you, and they're highly qualified and they have all these specialized monitors and equipment to do so. But some things that you can do is quit smoking at least 8 weeks before surgery. That's going to help minimize or reduce any complications you have from the lungs.
Say that
Reduce.
one more time. Say that one more time, Dr. Hunter,
Oh,
about smokers.
so yes, smoking increases your risk for so many different conditions, and then it has a potential to complicate anesthesia, but we still know how to manage you regardless if you're an active smoker or not. But it is very important for you to minimize your smoking, if not be able to quit at least 8 weeks beforehand.
Okay.
Reducing your alcohol intake, diet, exercise, working on reducing your stress levels, whether that be in the form of prayer, meditation, and then also just taking your prescribed medications. So that's going to help control your high blood pressure, your diabetes, any heart disease. So if they are better managed, we will be able to deliver anesthesia a lot smoother and better for you. And then, if you have any questions specifically for your anesthesiologist or surgeon, don't be afraid to ask.
Right.
And some institutions do have an anesthesia clinic where you can schedule an appointment and speak to an anesthesia provider about the risk of your upcoming surgery. And reach out to your surgeon and ask them if that is a possibility. So you can speak to someone before your surgery if you do have any specific concerns, as opposed to waiting to the day of, because as most of you know, you will not meet your anesthesiologist until the morning or the day of your surgery.
Right. Right.
Okay. So hopefully now you will view anesthesiologists as the doctors that's going to safely get you through surgery and keep you alive during surgery, as opposed to being extremely afraid to being put under.
Yeah.
Any questions?
Mr. Hunter, thank you so much. It was just so much information, and I'm looking at some of the comments that were going on, and people were really thankful that we had this session about anesthesia because, again, of the fear of being put to sleep. And I'm so glad that you came on to be with us on today. You answered a lot of questions. And you know how I do when I'm at work. I ask you a whole bunch of questions about anything that I need to know. I ask Dr. Hunter this and Dr. Hunter that, and what about this and what about that? And, and I share the information that I receive from my doctors, and I'm so glad that you just took the time to be with us today. And I thank God for our pastor allowing us to have these type of sessions, informative sessions, because he is all about getting resources and information out to the people. And one thing that people are having, and that is surgeries. And they want to be able to know that they will be safe, and the person that's doing their anesthesia knows what they're doing, and taking away some of the myths that we have heard over the years and about being put to sleep and paralyzed and not waking up and not being able to put to sleep. Some people, I've heard horror stories about, the anesthesia folks thought they were asleep, but they could hear everything and they could feel everything, but they couldn't say anything. So, thank you so much for coming on and taking this time to give the people information. Again, today we were talking about being afraid of anesthesia, being afraid to being put to sleep. But hopefully Dr. Nakia Hunter, MD, has put those fears to rest, and that it has calmed you about when you're getting ready to have any type of procedure, any type, and it doesn't matter what the procedure is, that it encourages you to not to put that surgery or that procedure off for fear, and ask questions, ask more questions, and more questions about it. Again, Pastor Edie, we thank you so much for this opportunity. Lady Edie, we thank you for allowing us as well to be on and talk about the fear of anesthesia. Let me calm your fears. And I just want to say this. Some of you are looking at Dr. Hunter saying, "Oh, she looks so young and she looks like she's really done." I said, let me tell you one thing. She's a little bitty thing, but she knows what she's doing, and she takes care of the business. If y'all know what I'm talking about, she takes care of the business. She is nobody's pushover, and she knows what she's doing. So, Dr. Hunter, again, thank you. From the bottom.
Thank you for having me. This was a wonderful opportunity. And I love chances like this to reach out to the community, because it's not a lot of us in the medical profession. So you really have easy access to ask these sort of questions. So if you do have any other questions or concerns, you can find me or reach out to Sister McDavid and get my information. And I'm happy to ask any questions or come back and speak to you all in more depth if you like. Okay.
Thank you so much. Well, we thank you all for joining us today at the People's Church of the Harvest Church of God in Christ. And we got to get ready now for our 12 noon service. We want you to take a station break, go get a cracker or a cup of coffee, and come back with us on Facebook Live at 12 o'clock noon. Thank you again for joining us. See you
Bye-bye.
again next time. Bye-bye.